Hello and welcome to HSM 220. For today's class, we will be discussing healthcare financing and service delivery in the US. There are a couple of learning objectives, which is what I hope that at the end of this class, you're able to complete. For an example, by the end of the class, you should be able to describe key policies that are related to healthcare financing in the US, describe key policies that are related to service delivery in the US, and finally describe a couple of issues that are related to health financing and service delivery in the US. For the first objectives, before we get into that, I want to give you kind of an overview of what this lecture will be looking at. We'll look at healthcare policies and the attempts it has made in addressing issues like access, quality, and cost. Now, these issues related to access, quality, and cost are not unique to the US healthcare system. It's something that happens in all healthcare systems, but this course will focus on the US healthcare system. And on the financing side of it, we're going to look at healthcare spending in the US and compare that to healthcare spending in other countries. And then we're going to talk a little bit about cost containment, which I will explain what that means. Then on the side of delivery, from this going to be from two perspectives. For the provider perspective, we're going to look at workforce and look at antitrust regulations. Then, from the patient's perspective, we'll be looking at it from access to care and patients' rights. So that said, let's just get right into health financing. There are two ways, typically two ways that one measures healthcare financing, and it's either through national health expenditure or per capita spending. So, per capita spending is a way of looking at the national health expenditure in a granular perspective. Let me use, for example, if you had $5,000, let's say you're earning $5,000 and you have 10 people that are going to live off this $5,000, it's not the same thing as someone who has $5,000 and there's only going to be three people who are going to live off it. So, what the per capita spending does is it tries to look at the population of a country and compare it with the national spending, because that gives a much clearer view of what is happening with a country's health financing, rather than just looking at it from the overall number, that huge number, which does not fully reflect the health financing realities in the country. Right now, as it is till date, the US is still leading the world in both national health expenditure and per capita spending. The US is outspending everybody in the world, and this image here is from 2018, the data from 2018 that looked at per capita spending for a select number of countries, and you can see the US leading with $10,000 dollars plus per each US resident. So, however, you see places like Spain going like $3,000 per each resident of Spain, and then you have India doing a much lower number at $209 per each resident of India. But one thing you're going to notice is that most of the countries that are in front, on top are countries that are technically seen as developed countries. So you have Germany, Sweden, Canada, France, Japan, United States, and stuff. The closest country to spend on per capita spending compared to the US is Germany, and it's almost 50% less than what the US is spending on healthcare. And so, and this is a data from 2020. So the previous one was 2018, and this is 2020, where healthcare spending in the US just keeps increasing. Because in the previous data we have it at around $10,000, and now in 2020 we have it at $20,000. Sorry, my apologies, $11,000. So it is climbing higher, and it is doing so much more than other countries. From this data you can see that other countries are also increased their healthcare spending is also increasing. When you compare, for example, Germany in 2018 to Germany in 2020, the healthcare spending is increasing. However, on average, healthcare spending is around $5,000 around the world. The US is almost double of that. So the US is really, really spending a lot on healthcare. So while this course is not going to focus on the health outcomes, one of the things about how much the US is spending on healthcare is that it is not bringing about comparative health outcomes. So just because the US is spending so much on healthcare does not mean the US health the health um, the health outcome of US residents is better than all of these countries that the US is outspending. For most health diseases, the US is doing a lot poorer than all of these countries that it is, outspending when it comes to healthcare spending. So this is another graph to show how healthcare spending is comparing the US to countries in the OECD. This is a couple of countries that came up. They're kind of mostly in the Europe. US is not part of OECD, but a lot of them are in the Europe. But you can look at it to compare. And let's say this is comparing the spending according to the GDP, because sometimes you want to kind of look at it. Is the US spending so much money because the US has a lot of money, and the other countries not spending as much because they don't have a lot of money? So this is another way of trying to understand what's going on with there. And you have the US GDP being at $18.8 trillion, and then you have Switzerland is $675 billion, and then you have France, you have the UK, you have Korea, you have Turkey, and you have Poland. So a lot of them are not as wealthy as the US. But when you compare how much of the US spending is coming from government and or is compulsory from the public, a lot of it is, compared to the part of the spending that residents have to bear, the cost of healthcare that residents has to bear, it is a lot. When you compare that of the US, you see that almost the out of pocket spending that people have to be responsible for their own health financing is almost more than the spending that comes from public purse. However, in other countries, you can see that payment that is coming out of pocket is much smaller than the payment that is coming from the public fund. So, and the reason why this is like this is because a lot of these countries have what is called universal health coverage, and universal health coverage kind of pushes for more publicly funded healthcare rather than people having to pay out of pocket for their own health care. However, Korea and Turkey kind of have a mixture of public and private, that is working, even though it is quite largely universal health coverage. So, a bit more to talk about healthcare financing. Is that the delivery costs for preventive care or primary care are low and tend to have a much better healthcare outcomes than, say, tertiary care or secondary care. And that is one of the reasons why the US is seeing worse health outcomes than other countries where they have a lot of health spending going into preventive care. And when service delivery is kind of disease focused, such as the one that you find in secondary and tertiary care, the cost of delivering the services are often quite high, and the this is not proportionate to the health outcome. For example, just because you're spending, let's say, $1,000 on secondary or tertiary care doesn't mean you're getting $1,000 worth of improved health care. However, that is, with primary care, you're kind of seeing if you're spending $1,000 on primary care, when it comes to improvements of health status, you are looking like maybe like $3,000 worth of it. The US tends to kind of focus on secondary and tertiary care. That is one of the explanations for why, even though the US is spending so much on healthcare spending, it is not getting a commensurate healthcare outcome. So, and that's, the US really focuses on secondary care and primary on tertiary care. So, due to this disproportionate relationship, um, and this is in every healthcare system, when you're having to spend a little on healthcare, on primary care, and get a lot of return on investment versus spending a lot on secondary care and getting less return. Um, this happens everywhere, and that is one of the things where you have the concept of cost containment to be something that is very, very important when it comes to the health policy that is related to service delivery and to financing. The reason being that you have to contain the cost so that you don't end up spending a lot your money going into those type of spending that does not yield a lot of improvement when it comes to health status. So in this graph, you can see how it tries to set a scene about how health outcome and health medical expenditure are related. With the A, you have a situation whereby with this curve, the more there are some medical expenses that the more you spend, the higher the health outcome. And however, at this point, this is like the A is the sweet spot, whereby you have um, high health outcomes and low expenditure. And this is where a lot of primary care kind of resides. Then this is where a lot of secondary care kind of resides, where you see that in terms of what you're gaining in health outcomes is not com- proportionately related to the expenditure. So this is where B is. What happens is that when you go beyond B, any medical care that you are doing, it has minimum health benefits, and all you are just basically doing is incurring costs without getting much out of it. And an example of this would be delivering high tech treatment for terminal patients. Is costs a lot of money, and there's not much difference that comes when it comes to improvements in their health status. So there are a couple of things, policies that look at cost containment. You have one of them is controlling the supply, limiting the number of people who can be healthcare service providers, and another thing is to control costs. by putting a cap on the fees that can be charged for services. Another is trying to contain utilization, trying to kind of control the extent to which services can be provided and what services can be provided on public posts. So countries that have national health systems uh, are in a very good position to do cost containment. The reason is because it's like cooking in one pot, and you get to control what goes in and what goes out, because it's doing that. So they have a much better grasp of cost containment, and they can do that by restricting control by supply or limiting the payments that go for providers. The United States, however, has a multi-payer system that makes it very difficult to implement cost containment because there are too many vested interests, and it's very difficult to get everybody on the same table or the same page, and so that becomes a challenge for the U.S. healthcare system. So now we get into the second objectives, where we'll be focusing on service delivery. So with the provider related policies, we are looking at things like workforce shortage. So and some of the places we have seen shortage has been with nurses, and we've also seen that with rural health providers. And across the world, there is a critical shortage of frontline healthcare workers. This is happening everywhere, and there's some policies to address workforce shortage, whereby you find developed countries like the U.S. and Canada trying to offer nurses from developing countries like Philippines or like India, for them to come over to the US and take some form of certification and then start working. So what that does is that it attracts a lot of healthcare workers from developing countries to come into the US to work. But what that does is that those countries end up losing their healthcare staff. So that is a challenge when it comes to trying to address the problem of workforce shortage. So you can read, there's a link to this. You can click this to read a little bit more about this critical shortage. You can also click on this to read a bit more about how the nurse practitioner profession was created as another policy to try to combat the problem of workforce shortage. So another provider related delivery is with antitrust activities. So especially this comes very handy in the US, because the US has a very multiplayer healthcare system and a very booming private provider and private financing system, whereby mergers and acquisitions are things that happen just like you would have it happen in a business. So there is some level of activities or control that needs to be put in place such that you don't have health providers behaving in the way that they would typically behave as a commercial industry, because health does not necessarily function in the same way as other commercial products. So those antitrust activities can cover mergers and acquisitions. So those are the ones. Another thing that antitrust activities tries to do is related to price fixing and trying to boycott agreements that healthcare providers may make among themselves as a way of increasing fees. So that this way it kind of takes away competition, because everybody has decided we are going to take up, increase the price of things, and it gives the patient very little option about where to go. So this is what antitrust activities do try to address. Another thing that it does, it tries to combat this thing called pay for delay, drug patent settlements. What happens with the pay for delay is that you have companies that hold patents to drugs trying to negotiate or come to an agreement with generic manufacturers for them not to market their products uh, because even in as a way of moving people away from those prescription drugs that are still under patency, because medications that are still under patency cost so much more than generic medications, and they do the same function. So by getting the generic manufacturers not to market their generic version, that pushes market to those drugs that are still under patent. So this is what we call pay for delay. So the antitrust activities is goes in to try to prevent situations like that. So from the patient's perspective of policy, we have access to care. Access to care is very, very important when it comes to health service delivery. And one of the things that the WHO has really been trying to push for is the right to health. And the right to health states that all people need to have access to health services that they need when and where they need it without suffering financial hardship. So this is one of the ways that the WHO pushes for universal health coverage, because with universal health coverage is so much cheaper for the patients to be able to uh, have access to health care, because otherwise spending a lot of money on healthcare could mean the difference between being bankrupt or being able to eat. So this is something that is very big when it comes to access to care. Another thing to discuss with access to care is trying to understand that it's not just about the cost of services, but we also want to focus on the timely use of personal health services to achieve best health outcomes. So this is something that the Agency for Healthcare Research and Quality has been working on in trying to push for a timely use of services. And one of the ways that it focuses on that is on coverage, such that, for instance, insurance, having a way to provide affordable insurance, because if you don't have insurance or you don't have another way of paying for your health care and you 100% have to pay out of pocket, your entry into the healthcare system is very much restricted, because now you have to check all the time, can I afford this? Can I afford this? Meaning that there may be some necessary services that you need that you would choose not to take because you cannot afford it. So that is where entry to healthcare system comes in. And then on the service end, we are looking at having usual source of care. Usual source of care is something like having a primary care doctor, someone that you always go to, and someone who knows you and knows your medical history. That's really is very key when it comes to healthcare access. And lastly, you have been able to receive, care timely, and being when you need it, and not having to wait too long for services to be provided. And then having workforce that are capable, qualified, and culturally competent to be able to deliver services to a diverse population of patients. So another thing that with the service delivery is looking at patients' rights. There are a number of policies and laws that have been drafted and enacted to protect the rights of patients. You have informed consent here that you can click to learn more. You have the High-Tech Act that you can click to learn more. And I'm sure you guys know HIPAA. HIPAA is one of the most popular health policy law that it is around for patient safety, patients' rights. And then you have the Emergency Medical Treatment and Labor Act. So click on each of this link to learn more about these laws and how they try to protect patients' rights. So with the third objective, we're now going to look at some of the challenges that have been experienced in health financing and service delivery. So some of the issues that have been related to workforce is having insufficient supply of health providers of all types. It's not just in nursing that there is shortage. There's shortage in almost all genre of healthcare providers. I think mental health is another place that there's seeing critical shortage of the workforce. And then there's also problems that are with retaining people in healthcare profession, and you have some people having problems of burnout, and that creates a problem with retaining people. And then with burnout being very, very common complaint with the healthcare profession, and because you're having to deal with so many patients, and that can take a lot out of you, and some professionals are not able to do that for an extended period of time. And then also having to match the supply of clinical providers to the demands for their services. Sometimes there are some services that there's a lot of demand for, and then there are available providers, so that can create gaps as well. And then you also have the pressures of costs to have staff with less expensive professionals. Less expensive professionals does not mean less qualified professionals, mind you, but that's one of the things that comes in terms of determining how do we get a professional that is qualified and very skilled and still does not cost a lot of money as much as other ones would. So other issues that are related to care is having regular source of care is usually a way of measuring patients' access to care, how much access you have to care. If you have a regular source of care, is the likelihood that you're going to have good health outcomes is high. So that is one of the things that why it is good. So having regular source of care increases a patient's chances of receiving better coordinated care, of better treatment for chronic or acute health conditions, having fewer delays in between care for situation where you have continuum of care, and also having better access to preventive care. So it's really an important metrics when it comes to health outcomes. Unfortunately, regular source of care is one of the things that is quite influenced by social determinants of health, whereby you have racial and ethnic minorities being less likely than whites to have regular source of care. And this is even when you have accounted for their socioeconomic status, you looked at their health insurance and their medical conditions. So this is a challenge when it comes to access to care. So Hispanics are least likely to have regular source of care, and then followed by American Indians or Alaska Natives, and then you have African Americans, and then you have Asians. So some of the factors that have been found to contribute to having this lack of RSC among ethnic minorities include systemic racism, which is a big one that has not been successfully addressed in the US, and that seeps in even into the medical profession and healthcare system. You also have a problem of lack of health insurance, which the Affordable Care Act did, make attempts at solving that problem, but it still kind of exists. And then you have insufficient household income, and then have the language barrier that comes for those who have either English as a second language or they don't speak English at all. And then, poor demographic, being living quite far away from the places that they need care. Example would be in rural settings. And then have it lacking providers that can provide culturally appropriate services. You don't want a situation whereby patients are turned away from the needed services because the way that they perceive they are being treated by healthcare professionals. So that is some of the things to consider when it comes to access to care. So that's where we end for today's class. Please remember to ask any questions that you need further clarification for, and I'm always very happy to answer. Do you have a lovely day. Bye.